Good morning. Thank you, Mr. Chairwoman, and I'd like to thank the American Society of Internal Medicine for inviting me today to talk to you about the most recent guidelines regarding reflux and a touch on Barrett's esophagitis. The talk will go through definition, pathophysiology, but we'll concentrate mainly on diagnosis, therapy, and wind up with a conclusion. So we all know what Gerd is. It's a condition in which reflux of gastric contents into the esophagus results in symptoms and/or complications. It's objectively defined by the presence of characteristic mucosal injury seen at endoscopy and/or normal esophageal acid exposure and/or abnormal esophageal acid exposure demonstrated on a reflux monitoring study. So sometimes we see esophagitis on biopsy. Heartburn is associated with acid reflux, documented by esophageal pH monitoring, and heartburn usually is alleviated with anti-reflux therapy. We have to differentiate GERD from functional heartburn, which is a burning retrosternal discomfort, no symptom relief with PPI, and absence of evidence of any gastroesophageal acid reflux or esophageal eosinophilic esophagitis being the cause of the symptoms, the absence of major esophageal motility disorders. And all these must be present to diagnose functional dyspepsia and functional heartburn. And it's very important to differentiate functional heartburn from gastroesophageal reflux disease because of the difference in the way we treat them. From a pathophysiological standpoint, two major things we see with patients with reflux, either a hiatal hernia or a lower esophageal sphincter problem, whether it's a lower esophageal sphincter relaxation or increase in the transient lower esophageal sphincter relaxation episodes, which happens in about 75% of these patients. Obesity can play a role, dietary factors, delayed gastric emptying, as well as decreased salivation, which neutralizes the pH from the acid going back in the esophagus, and impaired esophageal acid clearance, as well as impaired tissue resistance. This is an important study that was done in the year 2004, where it looked at patients with reflux. With our therapy with PPI, what we're doing really, we're not changing the reflux episodes. What we're changing is the content of the refluxate. So we look here, these are normal, healthy individuals that looked at the reflux episodes in these patients, and we can see on the left, the yellow bar is the acid reflux. When we give them PPI, we just changed the refluxate content. We blocked the acid, the reflux episode is statistically the same between 116 and 96. From a symptomatic standpoint, the main symptoms of reflux is heartburn as well as regurgitation. But we have atypical symptoms, as we can see: cough, hoarseness, dyspnea, non-cardiac chest pain, laryngitis or pharyngitis, or a wide variety of other extraesophageal symptoms. So these extraintestinal manifestations need to be treated differently. For example, patients with laryngopharyngeal reflux should not be, the diagnosis should not be based on ENT examination, because abnormalities can happen more than 90% of healthy controls, and there's a poor concordance among observers. That's why the ACG recommends or suggests that against the diagnosis of laryngopharyngeal reflux based on laryngoscopy alone findings, and recommend additional testing that should be considered. The spectrum of reflux with its complications goes from erosive esophagitis, which is about 1/3 of patients, to NERD, non-esophageal reflux disease, to Barrett's esophagus, and development of strictures because of fibrosis, and the ultimate threat of esophageal adenocarcinoma. What are the diagnostic tools that we use for patients with reflux? Upper endoscopy is the mainstay. We can use esophageal manometry to assess motility of the esophagus. We can use ambulatory esophageal pH monitoring as well as impedance to check for the non-acidic refluxate. Radiological techniques, please do not do it. The ACG recommends against using any upper GI to assess for reflux because it's not accurate. And histology, we can see the pathology showing the reflux esophagitis on pathology. So when we do upper endoscopy, we grade, as gastroenterologists, we grade these reflux findings. Either grade A, we have small, less than 5 millimeter erosions. Grade B, a little longer erosions, but not crossing from one fold to another. And grade C and grade D, having the circumference of the esophagus being affected, and grade C less than 75% of the circumference of the esophagus being affected. So from an American College of Gastroenterology guidelines about when to do endoscopy, we recommend diagnostic endoscopy, ideally after PPIs are stopped for 2 to 4 weeks in patients whose classic Gerd symptoms do not respond adequately to an 8-week empiric trial of PPI or whose symptoms return when PPI are discontinued. Upper endoscopy is not required in the presence of typical Gerd symptoms unless symptoms persist after PPI therapy for 4 to 8 weeks. And upper endoscopy for patients with Gerd symptoms who also have alarm symptoms like dysphagia. Everybody with dysphagia should have an upper endoscopy. Weight loss, bleeding, vomiting, anemia, and risk factors for Barrett's, which I will discuss a little later. When we do the endoscopy, we'll look at the grade. So grade A is not sufficient for a definitive diagnosis of Gerd. So grade A, erosive esophagitis. Whereas grade B, with the right symptoms, it is suggestive of reflux. And LA grade C and D is virtually always diagnostic of Gerd, and we do not need to do any further assessment for these patients, as well as Barrett's esophagus being diagnostic for Gerd. LA grade C and D, erosive esophagitis, endoscopy is recommended after PPI therapy as a follow-up to assess for an underlying Barrett's. Again, when we do upper endoscopy, in the old days, we used to see 50-50 regarding erosive esophagitis and non-erosive reflux disease, whereas right now we're seeing about 70% patients with non-erosive reflux disease, NERD, if you will, in comparison to Gerd reflux esophagitis. So from a diagnosis standpoint, if we have a patient who has heartburn, do not respond to therapy, or symptoms recur, we do upper endoscopy, 30% will have erosive esophagitis and 70% will have normal. Then we proceed in these normal patients to pH testing. If the pH testing is abnormal, then we do have non-erosive reflux disease. If the pH testing is normal, then we associate these normality with the patient's symptoms, and we can say that the patient has reflux hypersensitivity if there is an association with the symptom index. And if there's no association with symptom index, then we're dealing with functional heartburn, which accounts for about 60% of these patients. Again, to put it another way, looking at the acid exposure time, if the acid exposure time is abnormal, we're dealing with NERD. If the acid exposure time is abnormal, we look at the symptom index, then we have a reflux hypersensitivity. If the symptom index does not associate with the normal acid exposure time, then we're dealing with functional heartburn. We're moving on to treatment. We go from lifestyle changes to pharmaceutical therapy to, right now, some new endoscopic procedures, as well as the conventional therapy with a Nissen fundoplication or a toupee, depending on the patient. From a lifestyle modification standpoint, we'll look at dietary changes, avoidance of caffeine, alcohol, chocolate, peppermint, something that we recommend to patients on a daily basis regarding their reflux. Avoiding meals 3 hours before bedtime, small frequent meals. Smoking cessation is very important. Position or elevation of the bed up to 15 to 30 degrees. Tight clothing, as well as the gum for neutralization of the acid with the saliva secretion. And weight loss, obesity, since it's definitely associated with the increase of the incidence of reflux. From a pharmacological therapy standpoint, antacids does only symptomatic therapy. Sucralfate is recommended by the ACG only for pregnant women. Prokinetic motility agents are recommended to be used only when there is objective evidence of gastroparesis. And moving on to anti-secretory agents like the H2 receptor antagonist and the proton pump inhibitors, that is the mainstay of our therapy. Baclofen, it does decrease the transient lower esophageal sphincter relaxations, and in this meta-analysis looked at the number of reflux episodes which has been decreased, as well as the average length of these reflux episodes with baclofen, and again, a decrease in the transient lower esophageal sphincter relaxation. But that comes with the expense of these horrible side effects to the patients, like drowsiness and dizziness. And the ACG do not recommend the use of baclofen in the absence of objective evidence of reflux. From an H2 receptor antagonist standpoint, they're not very effective in comparison to PPIs, only 20 to 40% healing of erosive esophagitis. And we need to be aware of development of tachyphylaxis within 2 to 6 weeks with these agents. So PPIs, we started with omeprazole, then lansoprazole, aripiprazole, and winded up with dexlansoprazole, which is the most recent kid on the block. We do have a delayed release or an immediate release with bicarbonate, which gives patients more symptomatic improvement when they take it. or faster symptomatic improvement, if you will. We have a dual delayed release with dexlansoprazole, which allows us to give the medicine before or after meals. And the newest kid on the block that was approved by the FDA about a month ago, which was approved in Japan more than 5 years ago, is the potassium competitive acid blockers. They are coming. They have been approved by the FDA for the treatment of H. pylori with a dual therapy or a triple therapy, our regular triple therapy. These are faster acting, longer acting, as well as prolonged acid suppression with them. And the effect starts from the first dose. So from a meta-analysis of endoscopic healing with PPIs, we can see that PPIs are the best. The healing rate can go up to 85 to 90, 95%, depending on the study that we look at. The ACG recommends treatment with PPI over treatment with H2 receptor antagonist for hearing and maintenance of erosive esophagitis. And for patients with extra esophageal manifestations of Gerd, the recommendation is to go for twice daily PPI for 8 to 12 weeks before additional testing. From a meta-analysis for PPI efficacy, again, if you have erosive esophagitis, these are the best responders. But then if you have extra intestinal manifestations like chest pain or cough or hoarseness, these respond less to our PPI therapy. And the ACG recommends that patients who have extra esophageal manifestations of Gerd without typical Gerd symptoms undergo reflux testing for evaluation before starting their PPI therapy. And for me, good luck getting this approved by the insurance companies. So from optimization of PPI therapy before doubling the dose, which we do on a regular basis, we look at the lifestyle modifications the patient have done, improve compliance, ensure the proper dosing time. Taking the PPI 30 to 60 minutes before meals is important to have a full effect, because you can lose up to 30, 40% of the effect if you take it after meals. Exception is the Dexlant or dexlansoprazole. Split PPI dosing. If the patient takes a dose in the morning and they have breakthrough symptoms at night, then you can split the dose, or vice versa. Add another anti-reflux medication to PPI once daily, which can help improve patient symptoms. The ACG, though, recommends against routine addition of medical therapies in PPI non-responders. So from a therapeutic standpoint, we looked at where a patient has a heartburn. We tried the PPI therapy, the patient improved, then we want to taper to the lowest possible dose. If there's no improvement or recurrence of symptoms, we go for upper endoscopy. We treat mucosal abnormalities, and then with upper endoscopy, if you have erosive reflux disease, you have your answer. You continue with your PPI. If the endoscopy is normal, you do your pH testing off therapy, off PPI, and you assess the acid exposure time. If the acid exposure time shows no reflux, then we move on to the patient having reflux hypersensitivity or functional heartburn. And that's different if the acid exposure time is high from these other patients where they have reflux hypersensitivity, and acid suppression therapy can be helpful in these patients who have acid exposure time more than 4 to 6%. Whereas patients with reflux hypersensitivity and functional heartburn do not respond to your PPI and acid suppressive therapy, and they need neuromodulators like tricyclic antidepressant, SSRIs, or even SNRIs, and hypnotherapy. We can't do a talk about Gerd without mentioning the complications of PPI, which has been in the news all over. And patients come in and say, what about this, doc, if I take PPI for a long period of time? Well, studies have not really shown definite association except for enteric infections, as well as patients with ascites and the possibility of SPP. And there was a stand from the American College of Gastroenterology saying that we really should talk to these patients and say that these studies have flaws. They're not considered definitive and do not establish a cause and effect relationship between PPIs and the adverse conditions. High-quality studies have found that PPIs do not significantly increase the risk of any of these conditions except intestinal infections. Nevertheless, we cannot exclude the possibility that PPIs might confer a small increase in the risk of developing these adverse conditions. So very important to discuss these with these patients. There is nothing proven. From a symptomatic non-acid reflux reduction therapy, we can use baclofen, bethanical, we can use prokinetic agents, but you have to really document that the patient has gastroparesis according to the ACG recommendations before you start these. And then if you have reflux hypersensitivity or the patient with functional heartburn, then you want to use the tricyclic antidepressants or the SSRIs. As mentioned, we always can go to surgery or endoscopic therapy, which I'll touch upon later. So from a Barrett's esophagus standpoint, we have to screen certain population for Barrett's. If we can put up the slides just for a couple of minutes. So certain population had to be screened for Barrett's esophagus, like the age more than 50, Caucasians, increased BMI, abdominal obesity, and family history of Barrett's esophagus or esophageal adenocarcinoma. The recommendations for follow-up for Barrett's, if you see a short segment Barrett's less than 3 centimeters, the new recommendations is to do the follow-up in 5 years. If it's a long segment, the follow-up in 3 years. And if you have an indefinite Barrett's esophagus or a low-grade dysplasia, the follow-up will be 6 months or 6 to 12 months, depending on the clinical scenario. Very important to assess the risk for progression of Barrett's. With this meta-analysis, age played a role, male sex, smoking, as well as the Barrett's esophagus length and the presence of low-grade dysplasia. From an anti-reflux surgery standpoint, patients who benefit the most are those who have severe reflux esophagitis, large hiatal hernias, and or persistent troublesome Gerd symptoms. And a lot of young patients don't want to go through long-term use of medications, the expense that is involved, and even heartburn when it's better on PPI therapy, but with persistent regurgitation, because regurgitation is not benefited from PPI standpoint. So who is the good surgical candidate? Predictors of good response is erosive esophagitis, markedly abnormal pH testing, good response to PPI, and poor response happens in poor response to PPI patients, normal mildly abnormal pH testing, and normal endoscopy. Looking at the difference between a PPI and surgery, there's no statistical significance with this study, with this analysis that looked at 5-year follow-up. And this is a VA trial that looked at a large number of patients for 10 years. Just to mention that about 62% of surgical patients go back to PPI therapy after 10 years. The new endoscopic therapeutic options in our armamentarium recommended by the ACG is TIF, which is a transoral incisional fundoplication, and the link system, which is the magnetic sphincter augmentation. The rest, Stretta is not approved and it's not recommended. And the other ones are also not recommended. I'm sorry about being late. I think this will be my last slide regarding endoscopic therapy. Thank you very much for your attention.